I'm ready. Good morning. Today is September 26, 2022, and it is 11:30 a.m. As a quorum of the board is in attendance, I would like to call to order this special call meeting of the Central Health Board of Managers. The first item of business is public communication. Members of the public who wish to make comments remotely during the public communication portion of this meeting must have registered with Central Health via the online form or by telephone no later than 10 a.m. today. Yersinia, did anyone register to make comments or sign up in person for the Board of Managers meeting? Hi, Yersinia.
Hi, Manager. We do not have anybody signed up to speak for public comment.
Thank you very much. Appreciate it. We will now proceed to the regular agenda. You have a question, Manager?
No, I just had a comment to make. I know that Commissioner Gomez intended to speak.
She will speak on the item.
Okay.
Okay? Well, it wasn't me. Are we all good? All right.
Don't even have a phone on.
Agenda item number 1, consider feedback given by individual Travis County Commissioners in their September 20th, 2022 meeting regarding the Central Health Fiscal Year 2023 budget and appropriate action regarding A, the reserves and issues related to the reserves discussed in the Central Health budget presentation, and B, Sendero Health plans, including related financial matters. Members, I'd like to welcome Commissioner Margaret Gomez, who will speak to agenda item number 1. Welcome, Commissioner. You can have a seat over at that end, so the cameras can catch your. Commissioner, we are very happy to have you with us this morning. And well, yeah, this morning, it's not afternoon yet. And so thank you for being here.
Thank you. I appreciate your welcoming me to be here today to make a few comments on this item. And I think it's because I want to be helpful. Now, there was a time when healthcare for the poor in Texas was only available through acts of charity. Church congregations, doctors and nurses, and other concerned citizens united to serve those in need. As our population has grown, the role of providing this care is largely shifted to government and taxpayers. Counties are statutorily responsible for providing health care to the poor in Texas. To best meet this responsibility, Senator Gonzalo Barrientos wrote legislation to create a hospital district or a health district. In 2004, Travis County voters approved the creation of Central Health. Once approved by the voters of Travis County, Central Health's board is made up of appointed officials, not elected officials. Their budget and tax rate must be approved by elected members of the Commissioners Court, especially the tax rate. We look at the budget, but it's based on the tax rate. The Central Health Board approves the budget and the tax rate to recommend to the Commissioners Court the final approval of the budget and tax rate. The fact that Central Health was tied to the Commissioners Court, whose role is to provide oversight and assure the community's healthcare monies are being used in the most effective way possible. By the way, have y'all found a solution to allergies? God, this is incredible for me. It's my health issue.
A giant vacuum.
And so the Commissioners Court exercises its duty to review and modify the budget and the tax rate. And I take these duties very seriously. There are some noble things in this budget that provide health care to the poor and the uninsured. For instance, the budget allocates $129 million to purchase health care services. It allocated $5.6 million to provide direct health care services, and it begins the financial implementation of the county's health equity plan, which I hope makes sure that all parts of the county have access to health care. There are, however, items in the budget that deserve scrutiny. For example, the budget proposes a tax rate that will bring in nearly $282 million. Yet this initial budget sets aside $101 million in reserves to be used at some future time for some future reason. This is in addition to the $226 million already set aside as a contingency reserve. These reserves have grown at a historic rate from $24.5 million in 2018 to $226 million last year. That is an increase of $204 million or 900% in just 4 years. Now, the Central Health is asking the community and the county to grow that reserve to $326 million in the next year. Even after repeated questioning, Central Health has yet to clearly communicate why such a large amount of reserves is necessary. If the Central Health budget is approved as presented, more money will be set aside in a contingency reserve than is proposed to be spent in the entire 2023 budget. From the beginning of the creation of Central Health, it was proposed that Sendero was in the red and could possibly be eliminated. I raised questions about that plan because they would be abandoning health care for the poor. Not too long ago, I learned that Sendero was asking the Central Health Board of Directors for permission to apply for Medicaid, and they were turned down. I asked during the hearing last week why Sendero needed permission to apply for Medicaid. After asking for a briefing by Sendero, we found out that Central Health Board members also serve on Sendero's Board of Directors, which makes Sendero controlled by Central Health. Sendero basically helps Central Health live up to its responsibility to meet the needs of indigents. During this year's hearing, the court heard about the opportunity for Sendero Health Plans, Central Health's nonprofit community health insurance company, to participate in Medicaid to serve the elderly and disabled indigents in Travis County. Besides, providing Medicaid can bring in about $15 million more in federal and state funds to the community for further investment in healthcare needs. We heard from the community members asking for further investment in community care, more doctors and nurses, and expanded health clinic operating hours. They asked for expanding the highly successful Untitled Chapter program to provide health insurance to more of the sickest of the sick in our county who are indigent. This program could result in $32.6 million in Affordable Care Act money coming back to our community for further investment in healthcare based on 2021 enrollment. Some estimates show that expanding the CHAP program to 2,000 participants in 2023 could bring as much as $80 million of ACA money back to our community. Commissioners Court heard from the Health Alliance of Austin musicians, HAM, about their appreciation for Central Health's insurance premium programs and the need for more such support. With that kind of powerful community feedback, Central Health should present commissioners a revised budget that addresses the unmet health needs that are left out of the first budget iteration. This budget should further increase health equity, access, and health care to more people by using $100 million proposed for the contingency reserve in the following manner. Add an additional $14 million to the existing $14 million in CHAP. Double community health unity care budget to $56 million. Enter the Star Plus Medicaid for $24 million and purchase 30,000 specialty care visits for $6 million. These amounts total $100 million. I expect that Austin musician premium support can be met with these additional amounts, as well as other needs today and not in the future. The community and the leadership look to Central Health to bring forth a revised budget that does more to serve urgent and unmet needs in our community. And that is my suggestion to you today. Thank you.
Thank
Any
you.
questions?
Thank you very much, Commissioner. and
Thank you.
We appreciate the fact that you took the time to come and meet with us and provide us the information. Are you willing to take questions? or-
Absolutely.
Okay. Any questions from any of the board members? Mr. Madwani?
Wait,
You got it.
we're good.
There it is.
Thank you, Chair Bell. And thank you, Commissioner Gomez, for being here. I appreciate, I think, the profundity of I think, specificity of number of references in what you've shared with us. And I specifically was curious about if you could maybe share with me how the Medicaid entry into the Medicaid would bring in $15 million additional.
That's my understanding from the presentations that I have heard. And that is that by investing in not only the Medicaid, but also enrolling more people into the Sendero insurance program, makes it possible for us to draw down funds to bring into this community. And I don't understand.
Is that Medicaid or insurance? Sorry,
Both of them.
so
Both of
that
them.
15 million would be both? Okay, so
No,
do you know Medicaid
no,
alone?
I think there's different amounts for the
Yeah, it's
Sendero
important for us to know those
enrollees and
amounts,
then
yeah.
for the Medicaid.
But we're talking about the budget. So what is the amount for Medicaid, I guess, from the presentations you saw?
I don't have that total information, I just have the knowledge that can be done.
Who gave those presentations? Or I
think
guess what's the data
Central,
founded
when
from?
y'all make presentations to the court?
Oh, we presented that there would be a
Yes.
$15 million upside to entering into Medicaid?
Mhm.
Okay.
And those
I-
are estimates, of course.
Understood. No, I just wanted to know the data behind those estimates and, because
Sure.
I don't remember seeing
Sure.
any presentation that said there would be a
And
15
I
million
think what
Medicaid upside.
And I think what concerns me is the hesitancy to draw down on federal funds that belong to this community. We do the community survey program to see what the needs are by people in the community. And then we realize that some of that, in order to draw down federal funds, and why is there a hesitancy to do that? We also
I
show
understand,
it,
Commissioner Gomez. I just want to ask some
Yeah.
questions.
Yeah, no,
So
that's
the
fine.
next question is around the.
Were you finished responding, Commissioner?
I don't think that was, she was asking questions. She was
Oh.
asking why. I wasn't.
I heard her still talking.
No, I understand. I just, given time and what we saw with the limitations of time specifically at the Commissioner's Court, I think we can all respect that we, have some pretty specific items that we need to cover here that are crucial to the care of many individuals. And so the next question was around specifically I think I heard a number that we could bring up to 32.6 million from the CHAP program. And do you know where the numbers from that came from either?
it comes from presentation, I think that we had from Sendero, and then previously presentations by the Central Board to the Commissioner's Court.
Okay. And so in the absence, so right now, for example, Medicaid is being provided through another insurer. In the absence of a change, what is, in your opinion, the impact of that?
That it comes back to help further health needs of indigents.
Yeah, how does that work exactly though?
Yeah, I
I mean,
really
it's
don't.
like one insurer versus another insurer. Right now, Medicaid is happening, right? So how does that work?
I
mean,
don't
like,
have those details, but I think those are, I would suggest to the board that you look into those possibilities.
okay,
Because you have more access to that information than I do.
right. Which I think is a very important point. We have
Sure.
more access to that information than you do. I think secondarily, you mentioned that Central Health controls the Sendero board. And this is something of a continuance of our conversation from last Tuesday, which surprised me quite a bit. As far as Central Health controlling the Sendero organization, you're saying that it controls the Sendero organization because there are board members affiliated with Central Health on the Sendero board, is that right?
Oh, absolutely.
And so by virtue of that, as you said, the county has the oversight, i.e. the court, and thank y'all for y'all's service. You have the oversight over the voluntary board who manages the Central Health organization. So who then, of course, manages the voluntary board over the Sendero organization. Are we saying that basically you control the Sendero board? Or how does that work?
Well, I guess to say control, I guess we do when we have oversight over your budget and your tax rate.
Mm-hmm.
I mean, it's us who have to vote on those
Right.
as a final decision.
And is there a danger in that, or is that good? Is that a good process?
That's the way the legislation is set up.
Right.
So
Okay. Yeah, that's how it's set up, right?
that's
And
what it's set
and
up.
that's also how the structures of Sendero are set up with the cascading similar governance model. So if it works at a top level, what is your concern with it cascading down? It seemed as if there was like some concern of a nefarious special interest or something like that. So I'm curious about that.
I think the issue that is brought up is that we look to the purpose of the legislation.
Mm-hmm.
Go to that, and it specifically says it's to address the health care of indigents
Mm-hmm.
in Travis County.
Mm-hmm.
And so whatever y'all have set up to set up a process for enrolling
Uh-huh.
the indigent,
Uh-huh.
and if Medicaid helps them and they want to apply for it, why would the board oppose their application?
Well, I don't know why. And I haven't seen anyone who opposes anyone's Medicaid. Are you talking about indigent folks who can apply for Medicaid?
I believe Sendero had to apply, according to the newspaper story that I read,
Mm-hmm.
to apply, to ask permission to apply for Medicaid, and the board turned them down.
The Sendero board turned them down.
No. Well, maybe the Sendero board turned them down, but this board also, the newspaper story said that it came to this board, and this board turned them down.
Thank you, Commissioner Gomez. Thanks for being here. I think we can all benefit from a little bit of better access to the facts, but in the interim, it's really meaningful I think it's a little delayed, a little 11th hour, a lot 11th hour at this point, but I do really appreciate that you're here, and it's really meaningful. I think it's the beginning of a change in how we will be engaging over the next fiscal year. Thank you.
It does not have to be 11th hour, and I think what I would suggest too is that submission of your budget to the Commissioner's Court is also 11th hour. And I would suggest that before the budget, your budget is finalized here with a vote or a recommendation to the Commissioner's Court, that we have a work session between this board and the Commissioner's Court, so that we can have at least 3 months, maybe 3 months preparation for what you're going to submit to the court. And we can kind of work those things out. But to bring it to the court, maybe just 2 weeks before we have to meet the deadline of approving it, it is kind of 11th hour.
Thank you,
That's
Chair.
not
I'll leave you to
helpful.
respond to
It's not
any
helpful
of that.
to you, and it's
appreciate
not
it.
helpful to the Commissioner's Court.
Thank you, Commissioner Gomez. I'd just like to say, my understanding of Medicaid and Star Plus comes from my work at the HHSC, and I ran the program. The state match and the federal match goes to the state.
Mhm.
The counties don't see anything.
Right.
Okay? The individuals that are eligible for Star Plus are eligible by Medicaid standards.
Mhm.
So in essence, any health plan that gets a Medicaid contract serves those eligibles. It doesn't have to be Sendero. And Sendero does not have a great financial benefit from engaging in a Medicaid contract. We've had that experience in the past. And in the past, we had to exit Medicaid because we were losing almost $1 million a month in trying to pay for those services. Now, the CEO, Mr. Durkowski, will tell you that Star Plus is different, and it is. It's about home modifications. It's about things that are not necessarily healthcare services in the traditional sense.
Mhm.
It helps people who are disabled and those that have intellectual disabilities to live a higher quality of life. HHSC funds that program very well, mainly because that population is fragile and they weren't real happy about their care being managed.
Mhm.
And so if you haven't had experience with that population and how to serve them appropriately, then it is a risk. It's a big risk that we're not going to do it right. And not only that, Sendero is contracting out that service to be provided. And as a board member, I want Sendero to succeed. But I also know we have had problems with third-party administrative contracts in the past. And I haven't been informed as a Sendero board member that there's a plan B if that happens. And if that does happen, and those fragile individuals fall through the cracks, there'll be a lot of people at the state that are not going to be happy, not only with us, all right, but with the fact that this population now has reason to believe that we're not serving them well. We're just trying to manage their benefits. And that, to me, is a large risk.
Mhm.
And so I hear what you're saying about Sendero, but I'm not quite sure that I understand your methodology of how it works.
Okay.
So again, I do appreciate the fact that you were here to provide us with your thoughts and with your suggestions. We are going to, as a board, understand what our reserves do, how they will be spent down over time, what those expenditures are, and what making a unplanned change, because we've thought this through. It doesn't seem like we've thought this through, but we've thought this through a lot. Our staff worked very, very hard to be able to present us with a structurally sound budget that we could actually know that almost any situation could hit us, and we actually were prepared for that risk.
Okay.
And our contingency reserves are part of that plan. So again, we definitely respect and appreciate your input, but we also want to look at it from the standpoint of not disappointing individuals that currently have services. And we may not disappoint them today or this year, but 5 years down the line, we may be facing some issues that without those contingency reserves, we're going to have to either do one of three things: raise taxes, cut services, or both. And I know there've been a number of times that we've looked back on actions of previous boards and said they've put us in certain positions that we're facing now. It's important, at least for me, and I can't speak for my other board members, but I think they are also in the position to say that we want to do what's best, not only while we are members of this board, but when there are those that come after us that are younger and have opportunities to do for our community what we continue to do for our community now. So again, thank you very much. I'm not sure, did Manager Valadez, I saw your hand. Did you have anything that you?
Yes, I do.
Well, then I will recognize you.
I'm going to first state this for the record. By HHSC rule, only 2 health insurance companies can provide Star Plus Medicaid services in Travis County. Only 2. We know that they are both from out of state. We also know they are for-profit corporations. On average, each of the 2 companies are managing $250 million in local Medicaid care dollars. Current net income for the 2 companies is $15 million each. It's about $30 million, $15 million profit to each of the 2 for-profit corporations that do not exist in Travis County. If Sendero were to apply and be one of those 2 companies, we know historically that Sendero is our local nonprofit, and that if there are any profits to be made by them, which would be about the $15 million that is being made by both companies factually, we know that that would be reinvested in our community because it always has been. We created Sendero. They are ours. Another thing is that local Star Plus Medicaid dollars that's a fact from HHS themselves. What else does it say here? I'm reading. This is based on a summary report on permanent risk adjustment. No. I guess it's a financial information source is the Texas Health and Human Services Commission, from them directly. So that's where we got the $15 million from. It was a $30 million for the 2 companies, and there are only 2 in Travis County. What we were trying to get is for Sendero to be one of the 2 companies. That's where it came from. And it was my understanding, and I'll need Jeff and Mike maybe to confirm this, or Jonathan if he was around. Previously, when Sendero was in the Medicaid market, there had been an understanding that there was going to be a 30% break in how much money would be charged to a not-for-profit health insurance company. So that means if you're a for-profit company operating here, patient comes to see the doctor gets charged, gets reimbursed at a set amount. But for the understanding from the legislature to us, the way I understood it, is that not-for-profit would get reimbursed, I guess, at the higher, I guess, it was a 30% breakdown. Somebody help me with that. So I guess the for-profits, what ended up happening is the not-for-profit and the for-profit corporations, health insurance companies, were being reimbursed. The doctors who provided services under those two companies, health or not-for-profit or for-profit, were being reimbursed at the same rate. The not-for-profit should have been reimbursed at a higher rate than the for-profit. They were not. They were reimbursed at the same. So what that was doing was, in fact, creating a net increase in costs that Sendero had to pay back. Am I kind of correct, at least on that last statement, Dr. Bell?
You're talking about Medicaid Star chip?
Yeah, the one that was the Medicaid that they were in before.
Yes.
So that is correct.
No, no, I didn't say that was
I'm sorry,
correct.
I'm waiting.
Okay.
I
I
was
said
asking.
that on the Medicaid Star chip, the problem was that our hospital costs were too high.
Yes,
We did not negotiate an appropriate hospital cost that met the reimbursements that
Right.
we were getting from HHSC. That's number one.
okay,
The second problem was the fact that we had our case mix. And when we say case mix, we're talking about we were treating more serious cases than the rate was supporting.
Mhm.
Well, when you do that, you accumulate more cost
right,
that you have to pay for.
right.
And they're not going to give you any extra money
I
to
get
pay
that.
for that, which is why we had to exit.
So my question then, because I was under the impression that, do we have the right? Who negotiates that reimbursement rate? Isn't that a rate that's set by the state?
It's set.
It's set by the state.
It's set.
So wasn't there an understanding from legislators that there would be a lower reimbursement or higher reimbursement rate, or at least a discount given to a not-for-profit for their patients being seen?
All of the managed care entities receive the same
No,
rate
I
that's
understand that
set.
they received it, but it was my understanding that in the legislature, there was talk about it being negotiated less for the not-for-profit than for the for-profit corporations. And if I can ask Wes, was that the case or not?
We can talk about that under the Sendero item, but I
Well,
would
the
ask you.
only reason I'm bringing it up now is because it was brought up to Commissioner Gomez, and Commissioner Gomez is not in that world, okay? And I just wanted clarification.
Well, we can get
That's-
clarification. I don't want to keep.
So I guess
Commissioner
a
Gomez.
simple yes or no could be appropriate.
What is the question?
The question is whether or not there was talk in the legislature that there would be a difference in reimbursement rates for a not-for-profit and for-profit insurance.
The answer to that is
company.
no.
There was never that talk.
I can tell you what
Okay.
the argument was in the legislature.
Okay,
The legislators were upset because for-profits took their profit and gave it to their corporate offices.
right,
And it made the corporate offices richer.
that's right. Okay,
Our nonprofits did not do that.
that's right. I get
They
that.
kept that profit if they made them, because you have to be strong enough
To sustain that.
to sustain
I
those
get that.
profits.
I get that. So if we were to enter into Star Plus, and we know that we are a not-for-profit,
Mhm.
and we know that we're going to make about $15 million because there's only two insurance agencies doing Medicaid, not selling, but providing Medicaid in Travis County, that 15 million wouldn't go to any corporate office out of state.
That's correct.
It would remain here with us. Is that correct?
That
Is
is
that correct?
That is correct.
Okay, so hence.
Absent the fact of the strength, the financial strength of Sendero to be able to make those profits.
I get it. And I understand that perfectly. And so this is what has been a continuing concern of mine since I first got on this board, is the strength of Sendero relies on the strength of Central Health. And Central Health should be supporting what it created to provide that service. And if there is a difference in Central Health board members taking a vote not to provide that, then my question is why are we as Central Health, just for clarification and understanding, why is Central Health not supporting what it itself has created? That's to me a bottom line question. But aside from that, I personally believe that by having an additional tool in our tool belt, which would be the ability to provide Star Plus to the elderly and to the disabled, and if we were to support Sendero to the extent that it would need to be supported, we would know relatively quickly, because I think this is a multi-year contract, but we would know relatively quickly whether or not we were succeeding in that effort or not. And it would appear to me that if I'm someone who lives at that level, which I do, and has a child who participates in a similar program, which I have, that would be a great benefit to our community and to those families, because those families are struggling not only.
Mr. Valdez, if I may, counsel, should we call up both agenda items since the conversation is?
Appears to be.
We've gone into Sendero, yes.
Right.
Okay, so
Go ahead.
go ahead.
Well, as chair, I truly would not like to call up both agenda items. I would really like to end this conversation because I only wanted Manager Valadez to address any comments that Commissioner Gomez has. I do not want to keep the commissioner here during our deliberation. You're welcome to stay during our deliberations, but
Well,
I know that you probably have other things on your calendar that you have to go through. So if there are no other comments or questions for the commissioner, Manager Motwani and then Manager Musaiti.
And then
And I believe that this is public information that's been disclosed through the Central Health meeting and as well, obviously, and likely documents that can be obtained as far as the RFP submissions. But it should be pointed out that the administrator partner is also not in the RFP application or the proposal is not based in Austin, Texas.
that's right.
So just to be clear, and there's a substantial amount of revenue, obviously, in the administration of that work.
And the clarification to that is the two entities that are currently providing Medicaid Star Plus have affiliates that are Texas-based. So in essence, they are Texas companies. They're not out-of-state companies.
They're for-profit,
They are for-profit.
out-of-state companies.
No, for-profit in-state companies.
Okay. And if Sendero was to be a partner with someone who is based out of state, they would be in state. They would be here in Austin,
No, they're not
Texas.
affiliated. They're just a contractor. They're not Sendero affiliated. They have a contract
Okay,
with Sendero.
I
Very
understand.
different.
I understand the legalese.
Manager Musaiti.
Thank you, Chair. Thank you, Commissioner. Appreciate you here and your voice. My comment is more about a comment about the way how we've conducted our business in our budget. We've been working on this budget for the past year, and I want to really, I can only speak for myself, but it was through an equity lens and putting people first with this budget. It's not something that we just spontaneously decided that we want to put through. We had conducted how many meetings, several hours, probably, and staff has spent hundreds of hours working through this budget. And I really appreciate all the work and effort they have done from the bottom up to reach us where we're at today. And as a board member, every time we sat through any of our meetings, either publicly or in private or in our executive session, it's always about the people we serve. It's always about the patient. And it's not about just the money, making sure that we have risk, but also making sure that there's a sustainable plan that we have to provide the best adequate care for our community members. And we always have encouraged their voices in making sure that we work thoroughly. We've consulted with experts who are expert in this space, in financing. We are not experts in everything. And we wanted to also make sure that we had wise, sound advice and recommendation for us to move forward in years to come. So really, Mike, and that is really what I wanted to share with you. I know sometimes it may be misleading, but taking a deeper dive in the amount of time and effort that really took into place, and us spending many hours at night in several meetings, and we're really, yes, we are appointed individuals, but we're also volunteers. And if we did not care about this work, we would not be spending our afternoon here today or our evenings away from our families, because this work is meaningful and it matters. And every decision that we take, and I personally do not take it lightly. And the weeks coming to this budget, I attest to you, I do not sleep, making sure that that vote really exemplifies who we are in leading with integrity and making sure that we did our best and we are serving to the best of our knowledge. So thank you.
Thank you.
Thank you, Commissioner Gomez.
And let me just kind
Sure.
of say that I understand the position that y'all are in, but also understand that y'all are attached to the Commissioner's Court to report back to us what it is that you have gone through, how you've decided, what you're going to prioritize in your budget, and understand that it has to come to us to approve your tax rate, because only elected officials can approve tax rates, which lead to your budget. Y'all, I understand y'all approve a budget and you approve a tax rate, and it has to, but that's a recommendation to us. And then we can, of course, members of the court have other ideas, just like I have my ideas. And I think that the state has kind of left us all to our own to figure things out, and how we're going, not only what we're going to prioritize, but how we're going to fund that. And in this case, it's tax dollars. We have to tax our residents for the money with which we operate. And so for that reason alone, I am very concerned about how we tax our residents. Because sometimes basically what we say to our taxpayers is, we know better how to spend your money than you do. And if that's the case, then we have to prove it through a budget, through a tax rate. And so, and I think members of the court are also kind of have certain ideas about how things ought to operate. And I think that's why I'm suggesting a work session between the Commissioner's Court and this board 3 months ahead before the budget is due, when we can kind of talk about these ideas. Let members of the court know how the state operates in terms of Medicaid and other things, and so that we can kind of come to a consensus of what the tax rate ought to be, what the budget should be, where we ought to concentrate our resources, And I think it would be a much better, a much smoother way of operation. And so I hope that we can do that in the future. Our board, our commissioners, court members have a lot of questions too. But do we spend the time that you do on this business? No. I mean, we have a lot of things come before us that we have to kind of learn quickly and make a decision. And so, but that's the job. We know that's what the job is about, and yet we run for it anyway. But we do the best we can. And we try to do the best we can too by appointing citizens that we know will spend time on this board. Will spend time thinking about the needs of the people who are the recipients of this legislation. The legislation is the reason this board exists. And so we go back to that. Every time that we kind of lose our way a little bit, wait a minute, go back to why are we here? Who said we're supposed to be here? And who said that we had these duties? So, I mean, it's kind of simple to me. I've done this so many years. I think I know it by heart. So, but thank y'all very much for agreeing to address this issue. It's very, very important to all of us, and especially for those people who are poor, who are indigent, and for whom this legislation was written. So thank y'all. I think I'll join y'all just for a short while.
Sure.
And
You're
so,
welcome
but
to
did
stay
anybody
as-
else have any questions?
Okay, Manager Jones?
Well, thanks very much, Commissioner, for joining us here. I don't have a question. I just want to make a brief comment. And this is something I've shared with my colleagues here, and I'm sharing with you. The model we have here in Travis County for the provision of healthcare for the indigent is somewhat unique to the major urban centers of Texas. And in my philosophy, in my belief, is that that is part of the problems we face, in the sense that we are not truly we're moving that way, but we're not there now, a service delivery model. We're a financing district, basically. And so a lot of the things that you talked about and a lot of things we've talked about here, we're trying to get to, but under the current model that we currently have, it defers decisions and many implementation to contractors that we have. So I think that as we evolve as a district, it is hopefully that those kinds of things will be able to be addressed, so that those concerns that you're raising here, and other commissioners as well, will see that the board is truly impacting service and not necessarily financing only. And so I just wanted to make that comment, because I think it's important to understand that I concur with you that a lot of the challenges that we face here are, in my view, are based upon the model that we currently have. Not all, but many of them. And so I just want to make that comment.
Sure.
Thank you, Manager Jones. Manager Valadez?
Thank you, Commissioner, for being here.
Thank you.
And I just want to tell you that I appreciate your hard work, your support of our indigent, of our working poor, and our uninsured in Travis County. I think that's the bottom line for all of us. But what I am especially concerned about, and this is a conversation we as a board have to deal with amongst ourselves, is our priority.
Mm-hmm.
So as far as I'm concerned, when we look at development of a budget, who are we going to be providing services for? Who is going to benefit from the money that we're receiving? As far as I'm concerned, number one is going to be our indigent, our uninsured, and our working poor. And how much is that going to cost for us to take care of as many people as we can? That should be number one. Last on my list are the rich entities that exist and do not appear to be responsible for an accounting of how they spend the money that we are giving them freely, and not getting anything back, in any information that we should be receiving, as any business efficiently run should do. And if that's an issue with us in approving contracts that lawyers have given to us and recommended that we sign, then we have to really truly examine that and see whether or not we need new lawyers. Because we should never have contracts that do not allow us access to information as to what you are doing with our tax dollars. And if we don't have that, then we're doing a disservice to not only the community, but we're doing a disservice. And not only that, as far as I'm concerned, it's almost an abusive abuse of what services and what monies and what resources should be made available to the population, the poverty population, which we were created to provide services to. And I appreciated the comments, the thoughtful comments about expanding CHAP, because they're providing our sickest, neediest patients with access to comprehensive health insurance. I think that is an excellent suggestion. I think that MAP needs to be expanded. And as people complain, well, that's going to take too much money, it's going to be too expensive. Well, it's better than spending 35 million plus whatever we have to pay and not getting any information back as to whom they're providing services to, or to a hospital that is not providing us detailed information for the patients that we are forwarding to them, but that they and we are both responsible for. Those are all things that we need to re-examine and evaluate as to using our mission as the standard for how we're going to act and what we're going to recommend. One more thing before you leave. There was a comment made before you that there were only 3 people that were associated on the Sendero board with Central Health. There are 5. 5 of the 7 appointees are Central Health affiliated. Carl Ritchie used to be the chair for Central Health. He was appointed to Sendero and is still on the Sendero board. That name was not mentioned, if I'm not mistaken.
You're not true.
That's not true? He was never on Central Health?
He was on the Central Health Board.
Okay,
He
so
was not chair.
that's okay. He doesn't have to be chair. He was on the Central Health Board and he is on the Sendero board. In addition to Amit, Dr. Bell, and then staff people, Jeff and Juan Garza. So that's 5 people of the 7 that are Central Health associated or affiliated, not 3. And I want that to be corrected for the record. Thank you.
Thank you very much.
Chair, with respect to comments around the composition of the board,
I'm going to move that to the Sendero item. I'm trying to sort of separate
Understood. Thank
things so that we're not here for 24 hours. So yes, we can address that, but we will address it under the Sendero item. Any further questions or comments for Commissioner Gomez?
One more.
Quick.
I just want to say, I also agree that before we get into making heavy duty recommendations like the budget to you, working session is perfect. The same thing for us to enter the Medicaid Star Plus market or anything different. We should have a meeting with the Sendero board and staff to talk about it before it is done, not after the fact. And I do feel that we've had several missed opportunities to have that conversation, but so long, maybe they're not missed, so long as there is still time to have a robust discussion about them and the application time has not closed. Maybe we can consider that for our Central Health Board agenda with Sendero staff and their board. And let's see how that can be worked out, if at all possible, which I hope so.
And I do agree with Manager Valadez. I think a working session would be good. I think that more communication with the Commissioners Court would be a benefit for both our board and for the commissioners. And being able to outline not only our budget, but some of these very complex concepts associated with healthcare and healthcare delivery.
Right.
As you know, we've said many times in Commissioners Court, it's a complex and complicated issue. And there are many facets of it that are very difficult to understand. I mean, similar to the tax rate, I think sometimes that's very difficult to understand. So having those and being able to set those up would be very much a benefit, and we would appreciate your support to do that.
Thanks so much.
Manager Saito, must be quick.
Yes, it is. Thank you. Following up on that, because many, half of us are appointed by the city, maybe also collaborate at the city and county on these working groups can be beneficial for the overall Travis County community. Thank you.
I think the idea that I've heard of and is to invite the city if they wanted to join and allow them to sort of partake in the discussions if they choose to do so.
Sure.
So thank you very much. We
Thank you.
appreciate it. And again, you're welcome to stay throughout the entire discussion, but you don't have to be on the spot.
But I need to change over to this chair.
You
right?
can sit there and that'll be perfect. Because we've got some other presenters
Thank
that are
you
gonna
so
come
much.
up. Okay, let me get back to my agenda. Okay, members, I appreciate your valuable time for this meeting. My goal is to hold it to 2 hours. We're already 5 minutes off the hour right now, so I would hope that our deliberations and our dialogue will be not only succinct, but to the point. Not only should you listen to what others are saying, but also try your best not to repeat what others have already given us. I would like to personally thank Amit Matwani and Cynthia Valadez for their attendance and input at the Commissioners Court's meetings. I was unable to attend due to a conflict that could not be rescheduled, but I did view some of the streaming feed at the meeting. I recall this meeting at the request of Manager Valadez to discuss the input provided at the September 20th, 2022 Commissioners Court meeting. I will not ask for a motion to limit discussion, but I will informally allow each member to provide 5 minutes worth of comments and questions or statements on the statements that are outlined. I ask that members who want to propose a change to the central health staff recommendations outlined in the information that you will be receiving to provide support for those suggested changes and why you feel going against the staff's recommendation is in the best interest of the people that we serve and the financial health of Central Health, Sendero, and Community Care. Any questions at this point? If not,
Thank you.
I would like to ask Jeff Knodel and Lisa Owens to refresh our memory regarding the importance of the contingency reserves and the impact of significant unplanned changes to those reserves. Jeff, Lisa, thanks.
Thank you, Chair Bell. Thanks for having us here today. It's always a pleasure to visit related to our reserves. It's a necessary financial structure that all well-run organizations have, and we appreciate the opportunity to talk about it today. We're going to do a couple things. We're going to look at our reserves just as a refresher. We have a financial forecasting model that we present not only pre-budget in our financial forecast process, but we present throughout our budget process. And so we're going to go over that in a little bit more detail. And just as a reminder, we tend to look at our financial picture a little longer term. You'll see that we try to accommodate planned events. And we also structure our policies based on best practices, and we'll talk a little bit about that. So I'm going to turn it over to Lisa to walk through our initial or our financial forecast model and look at this future 8-year period and walk through our reserve levels and some more detail on anticipated financial implications over that period.
Thank you, Lisa Owens, Deputy CFO. So we wanted to provide additional detail about what's in our budget and what's in our long-term forecast. We looked out 8 years this year. So to orient you to this slide, it has a slightly different lines in the line graph than what you saw on the long-term forecast, so that we could show the sources and uses that we anticipate over the next 8 years. And then for the sake of this conversation, it's just showing the contingency reserve. It does not have the total reserves. And Jeff will talk a little bit more about the emergency reserve, but the trend line on that gray line is very similar in that you'll see our contingency reserves will be going down over the next 8 years. As we presented throughout the budget process, we estimate where we think we'll end up this year. And that column sets us up for starting the budget. We do anticipate that our sources of funds will be very incremental. And that is because we modeled this with a 6% year-over-year increase in the maintenance and operation, no new revenue rate, and also a modest continued growth of property values. So you'll see the sources line is very steady incremental growth. As well, we have been planning for some very known activities. The transition of the Community Care Collaborative, which is happening this year and has been happening a little bit last year, and additional entry into direct services. So in the call out boxes there, what you see are new costs. The uses of funds, which is the orange line, assumes once something is in the budget, like the direct services we're budgeting for in FY23, it will continue. And there's an inflator. For medical costs, we used a little bit higher inflator than things like supplies. But each of those has an inflator. So those continued costs are not called out. What we did was just call out new dollars that we anticipate would be going into the uses of funds. And you can see that we anticipate significant uses greater than sources in the next 8 years. In fact, we'd like to see that get closer together towards the end, but we continue to see that we are going to be spending more than we would bring in at a 6% year-over-year tax rate. So just a few things that we have been talking about over the past several years that are happening. I mentioned the CCC transition, but also beginning direct practice of medicine. As was recommended in our 2018 performance review, like many of our peers, there's a lack of specialty care. We did go to the legislature and began the process of direct medicine. Those are in this year's budget. However, if you look at the additional costs that we anticipate in FY24, that would be a full year of operating Rosewood Zaragoza Specialty Care Clinic, and that will be a significant increase in the costs than what's in this year's budget. In addition, respite services we have been talking about and additional services, and that full year of a UT affiliation payment, as well as we are opening 3 new clinics in the next coming years in Eastern Travis County, as well as the Rosewood Zaragoza Clinic, and in the very far out year, the Hancock Clinic. Those will have operating and facilities costs. Those dollars are built in the years that we think they will open. So we anticipate the operations of those buildings to be significant as well, in addition to the people that run those services. So you can see in FY25, expanded primary care, as well as the Colony Park clinic. Again, these are not specific numbers or opening dates. They're just estimates of when we think we'll be needing to hire people, pay utilities, et cetera. Additional respite care, and then additional specialty services incrementally going up a little bit less for Hancock. As you know, to start this direct service, we are going to bring on staff now to run the Rosewood Zaragoza Clinic that we may not need additional staff to run Hancock. There are positions that we'll need to run the direct practice of medicine to ensure that we have call centers, scheduling, specific staff that can oversee the entire program. So the incremental costs there are looking just at additional physicians and those operating costs. Again, this is 5 years out, so we're using very high level estimates. And what I'd really like to point out is this is based on what we know now. We have just begun a process for these health equity planning that will map out our financial and sustainability, how we're going to operate. And that information will be coming to the board and the public, and I'm sure the commissioners, as that work is completed this year. So again, we do have planned deficits. Those reserves will go down over time. This year, we anticipate them going down slightly as we embark on new direct practice of medicine and that additional $90.5 million we've been talking about in the healthcare services, and then additional facility costs and direct service specialty services in those future years. The next slide.
Yeah,
Do you want to jump in?
Yeah, let me jump in. So this has been can you go back to the other slide? Yeah, this has been a structure that we've used for a number of years. I think it's really served Central Health well in the sense that we've had a number of planned events that we've had to look at. And we've also had some unplanned events. But again, organizationally speaking, the use of reserves for both planned and unplanned events is financially prudent to look at. And you'll see over this long period of time that, we are basing our model off of a healthcare plan that the board adopted in February. It was a plan that took into account hundreds, if not thousands, of community input, persons participating in developing that plan, and a expert looking at our system gaps and telling us that we have a lot of gaps that are out there that need to be met. And that's what we're basing this future spend on, is fixing those gaps. If you remember back in 2018, we had a performance review that said that same thing. It said specialty care is a struggle for safety net systems. They looked at leading systems across the country and said it's a problem for everyone, but you need to go fix it for our patients, for our safety net system. And that's what we set out to do. I wish we could have done it in a year. I wish we could have done it in 2 years. These are very long-term strategic initiatives that take time. And from the financial perspective, I need to ensure that we have the financial resources in order to initiate those mandates. And I consider them mandates because we've been told multiple times that this is what needs to happen. So if I could go back to the first slide and just talk a little bit generally about reserves, and I'll turn it back over to Lisa to just visit our current model that you've seen. But, as it relates to Central Health, as it relates to what is our reserve strategy, I'm going to read what this first bullet says. It's essential that Central Health maintain adequate levels of reserves to mitigate current and future risk, which mean revenue shortfalls and unanticipated expenditures, and to ensure stable tax rates. Reserves also impact bond ratings and borrowing costs. As much as I would like to say, I did not make that up. This is guidance provided through the Government Finance Officers Association, which is an association of probably somewhere around 20,000 governments in North America that set best practices for government entities. They provide the guidance for us as we look at our financial policies. They provide a lot of guidance for the county, for Travis County. Travis County participates in their budget program and their financial reporting program.
May I ask a question?
Yes.
You mentioned the county. Yes, I think it's recommended that we have 11% reserves. What's recommended for y'all?
Well, what the policy says is it depends on your risk profile. We have a different risk profile than Travis County. Our target, we measure our target in days of cash on hand. Our target is 120 to 150 days. So, and you'll see that in the upcoming slides. We've shown that slide numerous times. It's just a different measurement.
But it's not measured in a percentage amount.
Well, you could measure it if you want to look at number of days for a year. Our target's 120 days. There are 360 days in a year. So you could measure it that way also. I know that the county has numerous reserves, just like we do. You have an allocated and an unallocated. So I don't know what you're referring to as far as specific reserve levels.
In reserve, that is not touchable. That's 11%.
Okay.
It has to be in that as a reserve, but it's untouchable.
Okay.
It's for disasters. It's for emergencies.
And again, we have an emergency reserve that fits that very need. It's 15%.
15% of that.
15% of planned expenditures.
Okay.
So again, there are different profiles for different entities.
Mm-hmm.
We are
Yeah.
healthcare centric. That
Right.
has a lot of, and I'll go through a couple of changes, but a lot more risk of changes that may happen in our area, in our arena, than the county may face in theirs. And that's usually indicative of bond ratings. And again, to Travis County's credit, they maintain a AAA rating, which is the highest rating. Being in the healthcare environment, the bond rating agencies recognize that there's much more volatility and uncertainty in that industry, and thus the need to maintain adequate or more reserves may be appropriate.
Right.
So as we look at the vehicle that we've used, over time, as I mentioned, we've used this successfully over time. And I think it's helped us maintain adequate reserve levels for planned events and unplanned events. And if you remember, some of those planned events started out with decreasing hospital lease revenues, the end of the Deseret program, and then certainly implementation that we've been talking about, implementation of the healthcare system plan that we've been discussing. There's also a number of unplanned events that have occurred over time. And when these happen, they're typically substantial, immediate, and can be very volatile. And so what does that mean? It means they happen quickly. They carry a significant financial implication. And the one thing that we don't want to do is to jeopardize our service levels to the point where we have the cushion or the financial ability to absorb that over time. And again, using a long-term planning process, we have those adequate levels to ensure that that happens. I'm going to turn it back over to Lisa to go through our total reserve slides. Again, one of them will be very familiar. This is what we've shown in the past. And then she'll walk through another scenario that we have related to our hospital days of cash on hand, which is our target that we look at in our long-term financial planning.
So as Jeff said, this is the chart. Only change since our last presentation to the Central Health Board is that we did true up that final budget. As you remember, we've made some additional investments in purchased services. So, but the assumptions and the out years are the same. And you'll see that with a 6% year over year tax rate and those sources being overuses from the previous slides, we do see a steady decline. So we will be using the contingency reserve over the next 8 years. On the next slide, we ran a scenario if we reduced our reserves by 100 million this year. So starting point, so took that extra 100 million off. And what you'll see is that our days of cash on hand goes below our target in FY28, and that our contingency reserve also remains on the decline, and that by FY30 would have approximately 60 million, but we would be well below the days of cash on hand. And I think all the other assumptions are the same, 6%. So as you know, we also, the timing on that would be that we would have just begun all of the services, opened all of our new clinics. And in those years, we would have to really be thinking in advance as to how we would make sure we were not in a low cash position, days of cash on hand with all those new operations. So there's two options, as Jeff has said, increasing the tax rate to something greater than 6%, and again, with these assumptions, or reducing services or expenses. So that's what that would look like, and I think that planning would need to start immediately so that we could incrementally make those changes. It's not something that we can do in 1 year. You want to add anything?
If I may, Mr. Chair.
Yeah,
So when you're thinking about the slide, if we could slide the camera visual in the upper left-hand corner down to one of the lower corners for purposes of seeing the slide title. So I think with a change of this scale, we would need to come back to the board and start building out some policies around this. It's not as simple as saying, well, let's make this decision. It really is a strategic redirection for us. And so I wanted to stress that, because even, looking at 6% year over year, this doesn't hold revenue constant. This actually increases revenues. That's a much different position to be in than where we're headed. So having some policies that we could come back to year over year, realizing, where things turn over and change, I think will be absolutely critical on this. Thank you.
Jeff? Thank you. And in closing, what I would like to point out is the board has adopted a health system plan that has looked at gaps, that has had a tremendous amount of community input. We have just started the second phase of this planning, which is implementation and sustainability. And so as we progress in that process, we will build those findings into our modeling and share that as part of the process. But we've built our modeling at this point of what we feel like the costs are that we need to do based on our system gaps that have already been identified related around specialty care. So I just wanted to point out, again, the reason for me to bringing this up is it takes a long time to sufficiently plan. And we are in the process of doing that. And that may potentially alter some of the findings, but we think that we are, our estimates are fairly accurate based on the information that we have today. The reason I bring all this up is I think we have substantial improvements that we need to make for our system. And my concern is that we've underestimated some of this and that we need to do further planning and further prioritization. So we don't know. I'm hopeful that we know that in 6 months, which is about the run of the engagement, and that we can report out to the Central Health Board and other interested governing bodies at that time. So thank you for allowing us to present on financial reserves, and if there are any questions, we'll certainly take any questions.
I will go around the room and ask for questions, but I would like to ask, we receive property taxes sort of in a bolus. I know that that doesn't mean anything to you guys, but in medicine, it means all at one time. All right? And we utilize those to continue to pay the expenses that we have, our ongoing expenses. So we have a set amount of services that are out there that we're paying for, right? And so we have to keep paying for it with that money. Our reserves kick in when we start bringing up programs that we have planned to bring up and expenses are starting to be made on those programs, and it's our reserves that fund those expenses. If we take away those reserves, we run the risk of not having money to be able to spend on those planned expenses that we've already put out there that we want to do. Is that correct?
Correct. So-
Jeff, but before, if I may, Mr. Chair, before you answer, I would also like to add to that, when you look at our healthcare equity plan and the operational plans that we're going to be bringing back to this board and the public and the court, it's also enrolling more people. Our health equity plans lay it out there for everybody to see. We take ownership of that, all the gaps in the healthcare system. And right now, we need to start looking at, in addition to adding those services and expanding, like you've mentioned, bringing more people on and doing more for more people. So there's a compounding factor here. It goes beyond just standing up a line of service like nephrology, for example. So I wanted to put that condition out there, but take it from there. Thank you.
And if I could add to that, Mike, if we had, and I'm making up this number, 5,000 employees, and we could bring up all of these programs simultaneously as we're delivering services, we wouldn't have a very large contingency, would we?
Not like we're, well, let me comment on what you're
First.
asking
Okay.
and what Mike, Mr. Giesland was adding. Our reserve levels peaked in fiscal year 2022, and we're looking at expanding our healthcare system, investing in our healthcare system, and we have some direction on that. Historically, we've known that we were going to do that, but we also knew that other events were going to happen. So the discontinuance of the Deseret program, we knew a while back that we would see substantially less lease revenue than we've had before. So our reliance on property tax is much greater than it's been. And the combination of those two events, when you want to look at sustainability and having adequate reserves, 8 years, whatever the time period is, you're going to have to build up reserves in order to do that. These are two competing elements. You have less revenue, more expenses, and expansion to your current system. That's a lot of moving pieces. And the prudent thing to do in that regard from a financial standpoint would be to build up reserves in order to accommodate those future costs that will incur in the next several years.
Thank you.
I have a question.
I'm going to start with.
Just for clarification. Most of the taxing entities came under the rule by the legislature that we were confined to the tax rate of the previous year to bring in the same amount of money as the previous year. And I guess we've been under that rule a couple of years now. And so we're contained at 3.2% over, or at 3.2% new revenue. Do health districts come under that rule?
No,
You did not come under that rule.
Currently, we do not. That's certainly a risk that we have looking out into the future. And again, our model that you saw was at a 6% year over year, right? So that's definitely a risk that we have forward looking, that there is some sort of legislation.
And I think there is a risk because taxpayers are complaining to us, but they say that we don't listen. So they go to the legislators. The legislators do listen. And so, there's that risk. And it's also, that's the risk of having too large of the reserves. Because the legislature will also look at that. Why do you need additional money? When you've got, this amount of money in there. So it's a double-edged sword. I understand your explanation for the reserves, but we also need to consider what the taxpayers out there in general think about reserves.
Well, and I think the point that I'm trying to make is we don't look at it year to year.
Yeah.
We have to plan long-term wise, and
understand.
that's what we're doing.
I understand that,
And,
because we're kind of in that boat too.
and if someone's looking at it year to year, I understand that.
Yeah.
There's just a different picture that
Sure.
we've deployed on the central health
Sure.
budgeting process.
But that's why I think it's important to invest in those programs where you're going to get, I don't know what they call it, but you're going to get paid back for investing in Sendero, your Medicaid. And so that's why that's important, because it keeps you're able to then continue funding that program without going into new money. Just
It's-
an added note, just what I've
And I
heard.
appreciate that. It's, the devil's in the details.
Yeah.
Yep, Eric.
And so, I probably know more of the details than most. And with other companies and other health plans, I would totally agree with you. So I'll leave it at that. Manager Jones, do you have any comments or questions? Really what I would like, we've heard staff recommendations of what changing our contingency reserves would do. All right, and it is a double-edged sword, like Commissioner Gomez says. In the short term, you look at people who say, oh my God, they have so much money that they're putting in the bank. But 3 years from now, when we're bringing up Colony Park and we go, we don't have the cash reserves, because a building without healthcare providers is just a building.
Yeah.
All right, that's it. And so we need to make it functional. So what I'd like the members to sort of opine on is, if you want to change it, and if you want to change our contingency reserve, what's the supporting reason that it would assist the people that we care about and that we serve now as well as into the future? And so that's what you'll be commenting on, so to speak.
Thanks very much. That's very helpful. There's a couple of questions. Don't leave, Jeff. I just have a quick question related to, I thought we had discussed when we were going to give public presentation, and I'm not sure, maybe we did, I may have missed that part of it. When we go before Commissioner's Court, that we're talking about the fact that our hospital district does not, or our healthcare district does not operate a hospital. And so the question is, the rate of taxes that we have compared to our counterparts in other municipalities is somewhat different. And I think that's important to understand. I just want to note that I don't know, when you're talking about reserves, is it possible, and probably not, but I just throw it out there, to look at what's happening in corresponding jurisdictions in the state, hospital districts and like, in terms of reserves they may have compared to ours, separate and apart from their hospitals versus our situation. I don't know if that's apples to apples or it can be done, but that might be helpful for us just to have a comparison. So I just raise that as a concern. This a question. I don't need to answer now. I just raise it, might look at. The second thing, I agree with what you just said, Chair Bell, in the sense that we find ourselves, in my view, 5, 10 years behind the 8 ball. This district has been in existence since 2004. And over that period of time, a lot has gone on, but we're still operationally in terms of service delivery. We're not where the citizens who voted for this district, or me being one of them, thought we would be. We're in the process of now catching up. In order to do that, we have to have a reserve to be able to mitigate and control that. So I think that the dollars that we have here are going to do that. The question is, how soon can we make that happen? And I think that's on us to put pressure on our facilities and operational things to get to that point. But I do think that the reserves are appropriate for what we have now, but we have to prove and we have to share. The commissioner didn't necessarily need to come to us to hear that this is what we're doing. And not just the commissioner. I think we need to be proactively, and we're doing a lot, Mike, to your credit, in the community in doing outreach about where we're going. But I think these dollars amount also might be helpful. This money is going to be used to do this over these next few years. I think that will go a long ways to helping people understand where we are with regards to the dollars we have. So
Totally agree.
those are my comments.
And that brings up another question. Is Central Health planning to get its own hospital?
Mr. Chair, may I take that
Yes,
question?
you can take that question.
Thank you. So as far as getting its own hospital, right now we are putting together our operational plans, and those will be ready for us to discuss with this board, the public, the commissioners court, sometime in the spring. Because we're going to be thoughtful about it and we're going to get them right. And within those operational plans, it's going to spell out, and there's two parts to this question, and I'm still on the first part, two parts to the answer rather. It's going to spell out what is the most efficacious way to go after these gaps that we have in the healthcare system, whether it's enrolling and engaging, whether it's filling a need by a line of service for a particular disease or a particular health condition to alleviate that disparity. So it's going to pull all of this together and it's going to map out for us, here's how you get there and over what period of time. Now, part of that conversation may involve expanded hospitals, access points in this county. I don't want to get out ahead of that analysis yet because we want to be real, again, very thoughtful, and also with the planning regions that we have and looking at areas where you have high concentrations of poverty and disease states. So all of that's coming. The second part to the answer is in our 5-year performance review. We need to go back and benchmark ourselves against other healthcare districts, but also looking forward, as Manager Jones and others on this board have said, which is, what of our role as a healthcare district in light of being a hospital district. Now, that is another point at which, and you'll see the discussions in the 1 to 3 year operational plans and the 5-year performance review overlap. If we do the 5-year performance review correctly, meaning we do a deep dive into this overall strategic approach. Now, there's a third part to this, which makes it difficult to discuss, but we're in a formal dispute resolution with Ascension. And so there's quite a bit around this that I feel like that once that resolution is put to bed, that we can have additional conversations.
And that's something that I would, that's why I'm recommending a work session with Commissioners Court and the city. I mean, we're all, whoever the partners are.
Well,
right.
We need to be on the same page at some point.
Commissioner, I'm glad you brought that up, and if I may, Mr. Chair, and I'm sorry, I need to go through the chair before I respond to your question, different form here. So thank you for your indulgence. I think that is a great starting point for a workshop, is to take those 1 to 3 year operational plans. I need to bring them to this body first. This is our governing body here. But then certainly when we have our community conversations and our workshops, that is the perfect topic to center on, because then you'll have something that you can look at. It's on paper. Like we sent you our healthcare equity plan to your office. I'm sure you've read through it all. It's a great read. We'll have something similar as that roadmap that I think then is tangible that we can all look at and have a discussion. That is an excellent suggestion.
But I also would insist that we need to have a working workshop on a work session on an issue like that. That's very important. But I'm not interested in having us all together and making political speeches.
No.
And then we wind up
That's
with
right.
2 or 3 hours or 4 hours of a meeting just made up of political speeches and no solutions
We
on
would,
the issue at hand. You know, so if it's going to be a political thing, I'm not interested. I want a work session where we talk about the issues, those hard facts about issues, making decisions for the people of Travis County.
Mr. Chair.
yes, sir.
So we would very much appreciate your leadership in helping us have it
Thank
be a
I'd
true
be happy to
work
help.
session and not a political forum, which well-intentioned, but leads us in the wrong direction for serving our patients.
Exactly.
Well said. Thank you.
Thank you, Commissioner. Manager Musaki.
Thank you so much. I definitely agree with you. It's people, not politics.
That's right.
And we are not politician by any means, nor do I personally aspire to be one. I respect,
Sometimes we're not very good politicians either.
well, I respect everyone who stepped in that foot. Now, what matters the most is really delivering high quality care to the people that we serve and ensuring that it's sustainable for years to come. Because it is unethical from us to start a program that is not well vetted and to bring on our patients who are in need and immediately need to cut it back because we're not able to finance it. That to me is unethical, unacceptable. I will never I'll put my name behind that initiative. So really what's really important for us is really implementing a program, a service that is sustainable for the long run, that is equitable, that is really patient-centered. And that's what everyone deserves, good quality of care, and that is, there's no fragmentation in that care. And also in addition, if healthcare is so complex, and if it was a simple equation, healthcare expenses wouldn't be the #1 bankruptcy in the United States of America. So it's not a simple equation, putting money in this bucket to that bucket and withdrawing money. There are caveats to these, to the health services and financing of the healthcare. Now, what presented to me personally, taking our reserves by 100 million, based on what was shared with us in thinking of sustainability, I do not favor that, and it will put us in a very uncomfortable position, and also will risk the services that we're providing currently and in the future for our patients. So with that, and with respect to everyone who proposed that suggestion to us, I am not in support because of it will not serve our patients well. And thank you, and I look forward to a future work session that we can really think about how we should deliver the best quality of care for our underserved population in Travis County. Thank you.
Thank you. Manager Motwani.
Thank you, Chair. And to Jeff and Lisa, as always, riveting. I think the detail of that presentation is helpful to see what a planned deficit looks like over the outlay of close to a decade, how the financial management of this organization has been so meticulously stewarded with that kind of long outlay outlook, and how we as a board have been apprised of that. I think the word I used was excruciatingly at the Commissioners Court meeting. I appreciate that. In my own experience, well, first of all, personal budgeting and, having worked alongside communities for quite a while, in the nonprofit world, financial literacy programs are a big thing. And typically one of the tenets that's communicated is, that 50, 30, 20, 50% of your income should go toward your fixed costs. 30% should be discretionary. 20% should be what you're saving over time in an ideal state. That's kind of, an aspirational thing. Now you can move those sliders around a little bit, but that's kind of a best practice for even family budgeting, which is far from, of course, commercial or organizational budgeting. I think also having about a half a year of cash on hand is important just in personal budgeting. Now in the nonprofit world, it's the same. And so I think recognizing that there's a core emergency reserve, and around that we'll have an operating reserve, and around that perhaps there may be a little more. I think it could be potentially flippant and at best, but dangerous at worst to underestimate what we need, not only to stand up new clinics, but then to maintain their ongoing costs. So like once you put up a clinic, you staff it, solve for all of the inflation associated with that, which is unprecedented at this moment, and then go with the ongoing costs, which of course continue to grow. It's an order of magnitude that's difficult to conceptualize. And I do very much agree with where we are now. And I also echo the comments, very astute, unsurprisingly, comments, of course, of Manager Jones around how we could do a better job of both ourselves being able to be far more well-versed in the granularity of how those dollars might be provisioned, at least at a high level, and how we might be able to communicate that out. And I think this is a great start to that. I also deeply agree with the potential work session notion for the following fiscal year of how we can maybe more closely work with the Commissioner's Court, who appears to be quite interested now. Thanks.
Thank you, Manager California. Manager Prince? No questions, no comments. Manager Valadez?
Yes, Jeff and Lisa, and I guess Jonathan, all of y'all have presented lots of information for us to take in and to evaluate, internalize as we deliberate. What I would like to know is, in looking at all the things, the initiatives, new clinics that are coming on, can I see you all here? I hate turning, do I turn around and look at you? Talk to you?
No.
Okay, well, then I'm gonna do that. Because as you all tell us what we're going to be looking at under the contingency funds, that's why we need contingency funds. Thank you. Then, how are we achieving, who is evaluating, or who is providing us with the efficiencies? What we're trying to do at Central Health is provide healthcare access to those that need it most. Okay, as we have since 2004 developed programming and healthcare services to address the needs of our targeted poverty population, have they gotten better? Who's assessing that? So is anybody assessing that? Well, no, let me finish, and then you can. Okay, so that's a question that I'd like to know. And I want to know what is being used to determine what that matrix is and how you're achieving that. And another thing, one of the things that I used to ask, and Coopwood used to be really good about, was making sure that we got community care responses for how their clinics are doing. Okay? I mean, how many people are being seen over at the Ben White Clinic, or William Cannon. I can remember William Cannon used to offer things, and then they came in. It wasn't Jason. It was I guess it was George Miller who came in and told us we need to shut it down because it's not being effective. So how many people are being seen at each of the clinics? Are they 100%? What services are being offered? Are they seeing patients at 100% or not? If they are not, like we know for a fact, there are clinics that are now only being open three days a week. Why? We still have bills to pay on operating them 7 days a week, but we're only opening them 3 days a week. That's very inefficient. So how are we assessing that inefficiency? How are we bringing it back in, comparing it to the long-term, medium, or short-term, medium-term, or long-term plan to see whether or not we're actually doing this for our sickest patients and increasing the health at the same time.
Manager Valadez,
And-
I don't want to interrupt you, but
Yes,
the question on the table is whether or not you support the staff recommendation with regard to contingency plan
okay.
or not.
Yes, so,
And if you don't, you need to give us information that supports why you.
well, all of this to me is relevant. Dr. Bell, in my head, it's relevant because I'm assessing where we're at right now. And where I would like to see us go is receiving those amounts, those pieces of information so that we can know every year where we're at. So we know what kind of a budget we need every year. Are our patients getting better? Are we achieving wellness, better wellness? Are they getting worse? Are we achieving what we are supposed to be? Why are we opening more clinics? We're going to have 7 clinics going to be open. 7? No, those things are important to me.
No,
And
I'm
the
not saying that they're not important,
no,
but we have looked at data. Sarita has provided us data that has showed by different populations improvements in certain health aspects and outcomes. And that actually gets to what you're talking about. So that information is out there.
I appreciate it. Thank you. So can I finish?
Yeah.
And can I finish uninterrupted?
Well,
Then
you can finish uninterrupted as long as you stay on the question.
Thank you, sir. I appreciate that. Those things are important to me, whether or not we're achieving the efficiencies that we need to be achieving, just like DSRIP, as he mentioned. We knew DSRIP was going to go away. And my question was, have we, through DSRIP, incorporated into our processes and practices all the good that came out of DSRIP, so that whether DSRIP stays or goes away is no difference. It makes no difference because we've already incorporated those things into our system, and we're achieving all the results that we anticipated achieving. That's important to me. What I look at right now is that there's still great need. There's still great need. And there's especially great need amongst those that are the sickest, those maybe 175 to 200,000 people that we have yet to touch. They have not participated in our MAP program. They're not in our CHAP program. They're not in anything. They're not in ACA. We have so many people that don't qualify and won't qualify for Medicaid because they're not legal citizens. Okay, they don't have status, but we could use them in MAP, and we could use those bodies in CHAP to help them achieve a higher quality of life. And so for me, in looking at whatever spectrum of services that we have to offer, the ability to go into the Star Plus program, especially for the elderly, of which I'm already there, but especially as we have seen growing in Travis County, that would be an opportunity for them to benefit from that particular program. I do believe that we can expand the number of CHAP patients. I do believe that would go a long way for also looking at, because of the wraparound services that would be offered, improving their care, at least stabilizing their care. And that is as important to me as them receiving direct medical care, the supports that they would be entitled to. I do think that maybe we don't need to spend $101 million on that. Community care, and the reason I brought up community care is because there has been talk about perhaps doubling their budget. And when I don't know whether or not all the clinics are actually being utilized, then I have a question as to whether or not that is a good recommendation. But in light of not having that information, because I've asked for it and we haven't received it, we haven't seen it, I really would hope that the working session that we have, that we start also having internally, we have enterprise working sessions, okay? I'm hoping that we mean the CCC is transitioning into, I think it means transitioning into Central Health. We're going to incorporate it into Central Health, correct? CCC. What does that mean? It says transition because it's
It's the Community Care Collaborative.
I know what that is.
All the staff have been transferred over, and those remaining contracts that are on the CCC will move over to Central Health.
Great.
That's in general. Then there's some nuances that we need to talk about at some point. But that's the gist of
Well,
it.
for me, that is a great thing because I never liked creating CCC because I didn't know what they did. I didn't have any input into what they did. But that's okay. So long as they come into our Central Health empire, our enterprise, that's even better because then we all have access to that information as it's presented. And we can all discuss, deliberate, and make a decision or recommendation. So I guess what I'm saying is that I support 100% the monies that Sendero may need to enter this new market. 100%. I support expanding CHAP. 100%. Because that also frees up more slots for MAP patients. One of the things that I have advocated for historically was expanding MAP from 6 months to a year. Okay, I'm glad we got them to change got ourselves to change the eligibility requirements so that we could actually offer more people MAP opportunities. When I came on the board, that was not the case. And so if there are things that we can do to ensure that that happens and achieve the goals of expanding MAP, expanding CHAP, providing Medicaid Star Plus to more patients or to our patients in Travis County, and actually being one of the entities as a nonprofit in-house, then I think that we have achieved something significant. There's always a risk, you know, the moon could fall apart. We could have a third world war. I don't know. There's always risk. But I think if we had serious conversations about that, there'll be calculated risks and things that we can look at our public in the eye. When I'm sitting there talking to Avat, who's already had one child die because she didn't qualify for Medicaid, and another one sick and dying right now, and still unable to get on Medicaid. And
You're at 7 minutes.
I'm sorry. So basically, I do support modifying our recommendations to the Commissioners Court, at least on our budget. But I also presented or submitted a motion that I wanted to make. And I don't know whether now is the time to do it or.
If you would like to make the motion, I think I would ask David to explain the motion that you have outlined.
Was there going to be no motion presented at this meeting? And is that my understanding?
I am not denying anyone from presenting a motion if they choose to do so.
Okay.
Manager Maflani.
To be clear, after hearing all of the feedback, I'm also inclined potentially to not necessarily make a motion, but I intend to ask you if there were a mechanism to possibly achieve something, which then might result in a motion. So would now be the time for that, or should we hear?
I submitted one. I sent one.
Yeah.
And I'm ready to submit it. We can take a vote on it. Then you can submit whatever you'd like to have submitted, I would think.
David.
So what Manager Valadez is proposing to do in the world of parliamentary procedure is to amend something previously adopted. That's what this motion is called. It is something that requires either prior notice at the previous meeting, in which case the vote is a majority vote, or if it is brought up at a subsequent meeting, it requires a 2/3 majority to pass. There is an ability to debate whether it's, because the alternative is what's called a motion to rescind, which just wipes out the previous action altogether. But the way I read it, that's not what this is. This is a motion to amend, not to.
Well, you're giving me more options.
we would have no budget if you rescind it.
No, I don't want to do that
Okay,
because we need to
so,
continue to operate.
This is a motion to amend something previously adopted, and the way I read Robert's rules requires either a 2/3 majority or, and this is straight out of the Robert's rules, or a vote of the majority of the entire membership, which would be 5. So the lesser of those two is a 2/3 of the members present. And doing some quick math, the only vote on which that matters, majority versus 2/3, is if 5 members vote. So if one of the 6 of you were to abstain, it's a 3 votes for it to pass if it's a majority, and 4 for the supermajority of 2/3. Otherwise, the numbers are the same. So it really doesn't make a lot of difference that's a 2/3 majority unless it's exactly 5 votes. So I just wanted to let everybody know what this is technically and how it has to proceed under Robert's rules.
Thank you very much, David. I appreciate it. Mike?
If I may come back to, there were a lot of points and some questions, Manager Valdez, within what you said, but there's 2 in particular that I'd like to address.
Sure.
Pleases the board. Thank you. So as mentioned earlier, there's a number of presentations that we bring back where we show healthcare data, and the board sees that. That is usually through the strategic planning committee meeting, but also our demographic report, which is coming out later this November, perhaps early December, depends on a lot of different work projects that we have. That's where we take neighborhoods that are that are, if you look at it through a social vulnerability lens,
Death Springs, Frostburg, etc.
and we show the disease disparities amongst several chronic diseases, at least 10 that I can think of. And so it's a heat mapping, if you will, that shows what happens, year over year over a 2-year run. And we'll also point out that, and this has been mentioned to this board before, there's a challenge there because you don't necessarily have a MAP patient throughout the course of that 2 years. So there's a longitudinal issue and a cohort issue, if you will, in that data. But that's something that we're going to continue to bring back still so that everybody can see it, not just the board, the public.
That's right.
And then on the available capacity, and this goes to what you were asking about, are we,
The clinics.
delivering care? That's precisely what you all adopted in February in the 1 to 3 year operational plans that we're bringing back that have been funded for this coming fiscal year, to be able to show you just that. Where is it that we need to backfill? And it's not always going to be a clinic, for instance. It's standing up a program that is more efficacious to addressing a certain disease state. And, right now, if you were to take a lot of money and dump it into a system or a program and you don't have the available capacity, it's like selling an airplane ticket, but you don't have a functional crew or a functioning plane. You just don't have it there. But that's why we're bringing these 1 to 3 year operational plans back to you so that there's integrity to it. And when we say to somebody, we're signing you up in MAP or you're signing up in Scenario Ideal Care, there's a place for you to go to get care.
I appreciate
And
that.
that's what we're working towards and trying to address those issues.
Well, those are the
you
kinds
raised.
of things that I believe we have had the capacity to do. And we have, I know I have asked for that information throughout my tenure on this board.
Well, you've got it here and it's coming in.
At some point in time, we
plan too as well.
actually got it. We got the breakdown on the clinics. We got the breakdown on the services that were being provided, but that stopped. And it stopped a few years ago. And what I want to do is make sure that we have that every year prior to our budget discussion, or that it be a part of our budget discussion, because I think it's completely relevant to seeing whether or not we're achieving our goal. And you can't operate without really knowing that and saying, we're going to have open all these clinics. We're going to have a new Hancock. We're going to have a new this. We're going to have a new that. Well, for the people that live in the Eastern Crescent that never had one, I think that's going to be great for people who live in the Eastern Crescent and can access that. And what we want to do is use that model, which was a successful suggestion on the part of the communities that live there, because they were putting money into our tax base and not receiving any services.
Okay.
Zero. And so that is the reason that it was successful in getting the 3 clinics. But we had already closed down the Northeast Clinic while I was here fighting that fight. We closed the Northeast Clinic. Now we're going to bring back Colony Park. So really, we're going to do a net of 2. And as far as I'm concerned, long overdue.
Okay.
So
Manager
my motion-
Valadez, if you would like to make your motion, please make it. My thought is, before you make your motion,
Yes, sir.
you were allowed to hear all the comments with regard to the people that are present to vote. So if you feel that your motion should be made, you go right ahead.
Well, I feel like I have to make the motion, and it'll be one way of everybody saying exactly what they feel.
That's
and
fine. Make it.
That's fine. Let's move. We can move forward, knowing that. Okay, so I originally asked for an additional $100 million to be included in the proposed Central Health budget, the 2023, adding that back into our budget. To ask that $45 million go to community care.
So I move,
I think I started out with I move.
but you didn't say it.
Oh, I didn't. Sorry. I move that that there be an additional $100 million added to the proposed Central Health budget for 2023, and that the well, I wanted to say 100 million, but I'm ready to go for a little less, but that's okay. What I really wanted money for is to provide additional $30 million for Sept Star Plus to provide Medicaid for the disabled and elderly, 1. For an additional $16 million for 2,000 additional persons to participate in CHAP for this 2023 fiscal year, 2. To increase the premium assistance program so that Ham and other musicians will be able to benefit by going into our Sendero health insurance plan. That's 3. That there be an additional $6 million for about 30,000 specialty appointments for MAP members. Those are the 4 that I really want to see funded until I get further information from community care as to why they're not using their clinics all the time. If it's an issue of money, that was going to be the additional 45 million to increase the reimbursement rate for the doctors or the providers. So if they would be operational most of the time, at least the clinics that we have in existence right now,
Okay.
operational.
There's a motion on the
Because
floor.
that's my motion.
There's a motion on the floor. Do I have a second? Manager Jones?
For the purpose of discussion, I'd like to second the
Yes, sir.
motion. Is that available for us to see? Because that's a lot of wording. I
Well,
just want to make
it's-
sure.
Mr. Chair, when
Yes.
we were having this discussion, I would
Yeah, that's what I was.
Okay, all right.
Do you want me to repeat it?
No, it was sent to us, and it's what you sent.
It's what I sent.
Yeah, we have a written purpose.
You-
With her revisions, did you change?
She did.
Oh, sorry.
She took one of them out. So number 1 is not.
The only reason that.
We understood the
Yes,
reason.
okay, was because we still are not sure as to why community care is not providing 100% operations of their facilities, unless it is in fact because they don't have the money to pay staff to be in those clinics.
We heard
Do we
that.
know that? Do we know
We-
that for a fact?
We heard that.
No, I'm asking for a question, a response. Do we know that that's the case?
I think the board needs to dispose of the motion and then I can come in and
That's
answer that
correct.
question.
That's correct.
So you need
And there's-
to
there-
follow through on the motion.
Okay.
I have a
Action.
motion. Did I have a second?
Yes,
So it was
yes.
Okay.
45
So I have a
million.
motion and I have a second. We're open for discussion. I would like to say that on those 2 items, we still have an item that we need to discuss with regard to Sendero that will add additional information with regard to the need for $30 million and the need for adding 2,000 individuals into the CHAP program. And so I don't necessarily know that it will inform your vote differently, but you're operating out in a vacuum with regard to that information at this point in time.
Then I ask further clarification of David, Duncan, and you, Dr. Bell. Is it possible for us to withhold all motions until after we hear both presentations?
That's perfect. That is perfect. You want to withdraw your
And I'm
motion?
withdrawing it for the moment.
Thank you very much.
Thank you, because I would like to hear that Sendero presentation.
Okay. Managers, we will begin this discussion of the Sendero sub-item in open session. However, if the discussion contains information about Sendero's financial projections or regulatory issues, I will interrupt the discussion and convene a closed session to continue the discussion. So please be clear when you start talking about future projections regarding Sendero or regulatory issues associated with Sendero. You will need to stop that discussion in open session and go into closed session because it could be detrimental to Sendero's competitive strategies within the market. As a reminder, Commissioner Gomez outlined the need for $30 million to Sendero. Manager Valadez has outlined the need for $30 million to Sendero. So we would like to look at that and also in the context of the Star Plus program. I've asked Chair of the Sendero Board, Betty DeLargy, to explain in more detail the memo that you received outlining the Sendero Board's recommendation not to pursue a Medicaid Star Plus contract. After Ms. DeLargy, I would like to ask Wes Durkowski to outline for us information that he provided to the Sendero Board that would suggest that implementing the Medicaid Star Plus contract is worth the risk of putting his current membership at risk and the financial sustainability of his company at risk for services that will already be provided to eligible citizens in Travis County. Betty?
Good afternoon, and thank you for inviting me to explain my memo to do so.
Microphone, please.
Sorry. There. First, let me thank the Central Health and the board for the past contributions you have made to Sendero. I think currently we are at 103 million that you have funded Sendero. You've been very generous and we do appreciate it. Thanks to the generosity of Central Health, we are where we are today and we do appreciate it. The Central Health, the Sendero board has spent quite a lot of time studying the Medicaid Star Plus proposal. This started several months ago, and I've explained some of this to you all at a previous meeting, and I'm sorry to repeat myself, but we started with quite a different proposal. It was for a proposal that would have brought us a risk share partner, because this proposal is for the Travis County area, which is actually 8 counties. It's Travis County, but it's 7 other counties that are contiguous to Travis County. That proposal evolved over time into what we have currently, which is Sendero on the risk with a third-party administrator that puts its administrative fee somewhat at risk. The intent is to obtain reinsurance once if the award is successful, if we obtain an award from HHSC. But you know, we're out in the reinsurance market. Reinsurance contracts are renewed every year, and we're subject to the market. So the Sendero board engaged a third-party consultant who has done quite a bit of work for Central Health Guidehouse to basically kick the tires for us and look at the proposal to tell us if this was the right path for Sendero, to look at the current plans who have this business. There are 2 in Travis County. There will be 2. There are quite a few bidders on this business. So, you know, whatever the results of this RFP, there will still be 2 providers of this coverage in Travis County. But we asked Guidehouse to take a hard look at what the probability was for Sendero, what the resulting financials would be, and to give us an honest opinion of what the results might be for us. We spent many hours reviewing the results. We had a 5-member steering committee, and we had at least 3 long conference calls. We reviewed a lot of financials, a lot of projections to arrive at our conclusions. This memo that I wrote you is actually not just my memo. It was a memo from the whole board. My name is on it, but it really was the composition of the whole Sendero board. And, you know, our conclusions was that we could not recommend this proposal to you for the reasons that are stated. The first one was that when we asked Guidehouse, they basically said that best case, we were looking at being short quite a significant amount of money. And worst case, it was a really significant amount of money that we would be short on this proposal. And that we could actually put our existing business at risk. If you go down to the insurance department, they will tell you that our primary concern should be the protection of our existing insureds. We have, as you know, we have CHAP insureds. We also have insureds that we have written through the marketplace, through the exchange. And our primary concern is to make sure that we have enough money to pay the claims of the people that we already have on the books. Before we go out and enter into a new market, we have to be sure that we've got enough money to take care of the people that we already insure. And so, I mean, that's really where we start is if we're going to undertake a new market, are we still able to take care of the people that we already have? And so the first conclusion was that we probably would not have, under our current financials, enough money to take care of our existing business and to take on this new risk. And to take on the new risk without anything changing could jeopardize our ability to pay the claims. The second conclusion was that there are adequate plans, other plans in the area, that if Sendero didn't enter the market, there would be other plans that take care of this business. There are other plans right now. It's a very competitive market. As Ms. Valadez pointed out, it's a very profitable market. It's a very competitive bid. In fact, there are plans who are maneuvering right now to get these bids. A third point was that Sendero itself has no experience administering this type of Medicaid plan. In fact, that is why Sendero had to seek a third-party administrator that does have some experience in this business. But, you know, we talked a lot about it, and what is important to the community is Sendero's relationship with its insureds. Unfortunately, this business would be administered in Pittsburgh. You know, Wes and I have talked a little bit, and I haven't gotten a good feel of how much, if any, of the services could actually be provided by Sendero employees. Maybe down the road, some of the services could be brought back to Austin, but my understanding is most of it would be done in Pittsburgh. It's not kind of the local touch that, you know, I think most people expect from Sendero, but that could change. I don't know. I don't want to get into anything of this because I think it is confidential information, but there are some other issues going on with regard to Sendero that we can talk about at another time. There was a lot of discussion about the benefit to the enterprise as a whole. And I think there was maybe a little bit of, maybe that wasn't as clear. It wasn't that we didn't fully discuss it. It was just there was some discussion of possible benefits to community, possible benefits to central health, but there was never really any discussion with those other entities of what those benefits would be or any validation of how those benefits would work out. And that was why we really couldn't bring those into our discussion to say that, well, yeah, that would really be a benefit to community and here's how it's documented and here's the, you know, the metric and here's how we validate. We couldn't really validate it, so we couldn't really bring that into our discussion. And the last point was one I mentioned earlier, is the fact that this is an 8-county bid. It's not just Travis County, it's Williamson County, it's Hayes County, it's Burnett, it's Caldwell, it's Fayette, it's Lee, and I probably left somebody out, but I have a hard time remembering the other 7 counties. And that really is where we got to. Now, I will tell you that if this is a proposal that Central Health wants to go forward on, the Sendero board will always do what's, you know, Central Health is the sole member, the sole owner of Sendero. Sendero exists to execute the mission of Central Health. We do not exist to act contrary to the wishes of Central Health. We exist to serve Central Health's mission. So, I mean, that's the Sendero Board's position. We're not here to be adverse in any way. Yes.
Thank you. And I just wanted to ask you, you said that you did not entertain that discussion with respect to other entities.
We didn't have any documentation, excuse me. We heard the discussion. There was a lot of assumptions made about benefits to community, but there was never any documentation or validation by community exactly how that would work.
Is that anything that's available now or not?
No, not quantified.
It's never been, yeah. Or to Central Health itself, it's not been. It was kind of a maybe.
Well, I guess I hear that, but the only concern I have is that I don't even know what that maybe is, because you haven't told us.
And neither have they.
No,
I don't
that's
know.
right, that's right. But I would hope that y'all would have, if there was an ability to quantify whatever possible benefit that could exist for Central Health or for the community, that would have been developed and provided.
I would agree with you, but I think that would not be the function of my board.
That's exactly right. And it's not a function of this board.
No.
It's a function of the CEO to bring us that information.
So you're saying that that's why it didn't come forward, because it wasn't brought forward by Wes?
Yes.
I'm not pointing fingers. I'm just saying,
I
we
understand.
really couldn't consider it because it wasn't validated. It
If
may
wasn't
exist,
validated, it wasn't
but
brought forward.
without any kind of statistics or validation or confirmation, it just really,
I understand you, but
Okay.
when I talk about benefits, I personally would like to know what they were. If I'm gonna have a wellness center open, or if I'm gonna have a clinic open, and people are gonna go to it, and they're gonna attend regularly, I would think that the benefit of that, even though we may not be able to see it, you would be able to kind of quantify it over the years, over the months, because you would see that their health is improved, and, there's less serious, I guess, diagnoses, of that. But I don't know what you're referring to here, and that's the only reason I was asking. And just not to be disrespectful, just to ask if there was a way to be able to say, well, this is a possible, but yet unquantifiable as of right now, benefit.
I would agree that it's possible, but not quantified. So you can't really use it as a validation of the proposal. That was my point.
Any other questions for Mr. Larby?
What about the capital requirement?
The capital requirement, the consultant said, and correct me if I got the numbers wrong, that it could be, best case was we were short 3 million, 2 to 3, and worst case it could be 19 million.
I would
I'm not good at-
probably ask, I don't know how much, because this is open session still, right?
Oh,
Oh,
sorry.
I'm sorry.
Oh, sorry.
No, it's
Do we need to
okay.
go into
I mean,
executive
these are
I'm gonna ask other
broad
members.
industry numbers, but if we're gonna,
session?
happy to talk more, but then
Sorry.
maybe
I apologize. Yeah.
if it's easier to go into closed or,
That's fine.
I'll wait.
Any other questions? Manager Jones?
Just a quick question. Do you have any information, excuse me, demographic information on your client, on your population? Would you happen to know that offhand?
On the existing insureds?
Yes. Percentage by race, ethnicity, and sex. I didn't
yeah, I
know.
think we shared some recently, and for a regular ACA population, we keep track with the community, but specifically for our programs in Central Health, the CHAP program,
Yeah, I'm
and the
talking about.
premium assistance programs. Yeah, there were, I can't remember the exact numbers, but it's equivalent than and greater than representation of minorities than the community, because we are focused in underserved areas.
I guess the reason I raised the question is that I've talked particularly in the Black community, and there's at least a large void of knowledge about Sendero. And my question goes to what kind of outreach are we doing to engage that community particularly, as well as others in terms of Sendero and its service.
Yeah, happy to talk about that. So that unfortunately is a reflection of the, need for more knowledge and education and outreach around healthcare in general. And remember, for Sendero, because we do have limited capital, we haven't been able to focus on the broader community. We focus more on these premium sub-assistance programs. So our membership is smaller. We still do a significant number of outreach events, but it would be different if we were functioning as like a regular community plan, with a more broad mandate.
Within the population you do serve,
Yes, yeah.
you have that, you can provide that later. I was just inquiring the data on that.
Sure, we can get that to you again. We'll get to this.
Thank you.
Thank you, Manager Jones. Manager Musaitik, just one second. Mr. Largy has a comment she would like to make to that discussion.
I think it might be helpful to go into closed session because I've
Okay.
already kind of gone over into it.
Yes. Okay. Manager Musaitik.
Appreciate you. Thank you. Mr. Larger, can you tell me more about your background? And I want to learn more about you, the composition of the board, their expertise and skills on the Sendero board. So when you bring forth a recommendation, I wanted the public to know who are those individuals who are providing that recommendation to us. Thank you.
I can try. I can talk about myself and try not to sound like I don't know. I'm retired. I'm supposed to be retired. I have practiced law for a long time in this particular area. I was a member of a partner in a law firm in Austin. I have represented health plans, HMOs, insurance companies, both local and national. I represented the state high-risk pool from the time it was funded till the time it was dissolved after ACA was effective. I worked with Mike when he was the Commissioner of Insurance on a lot of enforcement actions, not on his side, by the way. I represented companies who had enforcement actions filed against them. I've represented political subdivisions. Their self-funded plans primarily. I've represented some interlocal plans which were formed by political subdivisions for their self-funded health plans. I've represented self-funded employers. I've done some employee benefit work. I have to say my very favorite client was the high-risk pool because we were the insurer of last resort. It was it's basically a self-funded plan, but it was money collected from the insurance companies to pay for people who were turned down for coverage, people with terrible medical conditions. I learned so much from that client. It was the most gratifying work I've ever done. It was absolutely wonderful. I just learned an awful lot about people who needed catastrophic care, who frequently didn't have the money to pay for it. The pool had a wonderful premium subsidy that the legislature enacted. There were many wonderful things about it that ACA doesn't even begin to touch. The board of the risk pool, one of the longtime directors is a retired, I think he just recently retired insurance agent. I believe he worked for State Farm. Another is Carl Ritchie, who was on the Central Health Board at one time, but was a member of a law firm. I think he's primarily a lobbyist, but he is a lawyer. He's represented a lot of city governments. I think he's more in representing political subdivisions. I think he represents a wide variety of clients. I think a lot of you know Juan Garza. He's been, lots of different places, mostly in the public sector. I think
He was also CEO of a hospital.
Oh, that's right, he was.
Yeah,
Corpus.
in Corpus Christi.
In
In
Corpus
Corpus,
Christi.
that's right. Juan's been around.
Yeah, he sure has.
You know Dr. Bell, you know Jeff. Am I forgetting his name?
Amit.
Oh, Amit.
Eddie.
Oops, sorry. No, I mentioned Eddie.
Oh, forgive me,
Eddie
sorry.
is the retired insurance agent. So, we have a pretty diverse board. I make a joke that I'm the minority on the board. I'm the only woman.
Yeah.
And I'm really the newest member of the board. I was actually, Wes actually recruited me for the board. Probably the worst mistake he ever made, but.
No, you might be thinking his worst mistake. You might.
Yeah, well, that could be too. I was actually Sendero's outside counsel. And when Sendero had all of its troubles several years ago with the first Medicaid program, and with the risk adjustment going the wrong way, I was sitting by Wes for those meetings, sitting over in the corner thinking, oh.
I remember that.
Yeah, I mean, it was tough because we were coming to Central Health for some big contributions.
Well, thank you for your service, and enough said about you and everything that your
Sorry.
board and you bring to the table. Thank you.
Thank you.
Thank you, Manager Musaiti. Any other questions before we go into closed session? Hearing none, agenda item number 1B, which is consider feedback given by individual Travis County Commissioners in their September 20th, 2022 meeting regarding the Central Health Fiscal Year 2023 budget and appropriate action regarding B, Sendero Health Plans, including related financial matters. I announce that the board is convening in closed session to discuss agenda item number 1B under the Texas Government Code, Section 551071, consultation with attorney, and under the Texas Government Code, Section 551.085, governing board of certain providers of healthcare services. It is the 1:56 on the 26th of September. Okay, we are back into open session. It is 2:46. I'd like to recognize Manager Valadez for a motion.
Yes, sir. I move that Central Health spend additional millions of dollars in this way. To provide a capital reserve of 30 million for Sendero Star Plus for Medicaid to the disabled and elderly. To increase CHAP in the Sendero program by 16 million for 2,000 persons. To increase the premium assistance program by 3 million to extend assistance to Austin musicians. And then an additional 6 million for specialty care appointments to MAP members. So that's a total of 46, 49, 54 million.
I'm not good at math.
I think that's what it is.
That's
30,
okay.
46,
That's
anyway, in that way.
Okay, do I have a second? Okay, going once, going twice. We have no second.
Thank you.
All right,
It dies for lack of a second.
yes. Okay, members, agenda item number 2 is to confirm the next regular board meeting date, time, and location. Managers, our next Central Health, yes, ma'am.
I was gonna ask if I can make one more motion. Just in case, real fast.
All right,
Okay. I move that Central Health allow for an extended expenditure of 16 million to go to expanding the CHAP program by 2,000 people. The 3 million to extend premium assistance to Austin musicians. And 6 million for specialty care appointments for MAP members. With the proviso that we will be working and have the opportunity to continue to work with Sendero in looking to see how we can expand services to more people in Travis County. So,
I have a motion on the table. Do I have a second?
Chair Bell, the potential for a friendly amendment or what might make this more palatable to me is in my mind, but it's really complex. I want to honor, I think, the intent of Manager Valadez's motion, but I don't know if seconding it is the way to open the discussion around that. I don't quite know how to formulate a friendly amendment, given the specifics of what we're dealing with. And so I also know we're going to lose quorum in 10 minutes.
You are going to lose quorum because I've got Dr.
can't
Brinson
think of
is
the
making-
modification.
I would, yeah. So just
Okay.
given that, I can't offer a second.
That's fine.
But
Appreciate
you'll
the
likely
effort.
you'll likely be unimpressed by the notion that I also have a motion. And I do have a
Okay.
motion.
So mine died for lack of a second. You're gonna
Yes.
present yours now? I mean,
Yes, and I move that, and please, Dr. Bell, Mike and David, if I'm off, y'all will guide me, Dr. Brinson, but the motion would be that we resolve to work with the Commissioners Court to set up work sessions for the following fiscal year, 3 months, at minimum, at 3 months before the passage of the budget and tax rate, because I think that was a very, very important thing, and we should get that memorialized however we can.
I'll second that.
Okay, I have a motion by Manager Motwani. I have a second by Manager Musaite. Any further discussion?
will you consider adding to your language Commissioners Court and City Council?
Yes.
Thank you.
The motion has been amended to add City Council and Commissioners Court. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Thank you. I would also say that I think that further discussion will happen with regard to premium assistance for not only to Austin musicians, but other individuals within Travis County who fit within the equity plan of not receiving services and care. and also looking at, also looking at our specialty appointments and increasing Sendero's CHAP population. All right, agenda item number 2, confirm the next regular board meeting, date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, October the 26th, 2022 at 5 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez, Austin, Texas, 78702. I have a motion to adjourn by Manager Valadez. I have a second by Manager Brinson. Any further discussion? Hearing none, all in favor?
Aye.
We are adjourned.
Thank
Thank
you.
you.